and malignant issues, but it's the malignant issues that truly affect our society. We're just coming off Colorectal Cancer Awareness Month, and so these malignant issues or the cancers are quite in the forefront. So what exactly is the colon and the rectum? Well, essentially, it's a 6-foot-long, complex waste processing plant, so to speak. And the rectum makes up the lower 10 inches or so and serves to store the stool. Now, colon cancer is the third or the fourth now most commonly diagnosed cancer in the United States, striking about 140,000 people annually. It is the second leading cause of cancer deaths in the nation, with 50,000 deaths annually. Now, this is a staggering figure when you consider that the disease is potentially curable if diagnosed early. Colon cancer takes years to develop. We all have about a 5 to 6% chance of developing colorectal cancer in our lifetime, but it's more common in males. So who's at risk? The ugly truth, everyone's at risk. We all are at risk. There are certain factors which contribute, so age greater than 40, diet, low in fiber, high alcohol intake, high fat intake, processed foods, red meats, obesity, a lack of exercise, and then certain family history, like a parent or a sibling or immediate family member having the disease or having inflammatory bowel disease or polyps, or certain ethnicities like Ashkenazi Jews or African Americans are more predisposed. Most colorectal cancers occur after the age of 40 to 50, though it can occur at any age. But recently, there's been an increase in the incidence of cancer seen at a younger age group. And this has led to the American Cancer Society recently recommending that average screening now starts at 45 years if you're at average risk, meaning you're part of the regular population, you have no risk factors, no symptoms, no family history. How does colon cancer develop? Well, it's generally agreed that colon cancer starts as a benign polyp. And what is a polyp? A polyp is an abnormal growth that left in place has the potential to become cancer. Now, not all polyps are cancerous. There are different types of polyps. Some are completely benign, and others have varying potentials to develop into cancer. These pre-malignant growths occur on the bowel wall, and then they can grow in size and penetrate the bowel wall and become cancer. So removal of these benign polyps is one aspect of preventative medicine that really, really works. How do I know I have colorectal cancer? Most commonly, people will have bleeding from their bottom or a change in bowel habits or some constipation. But these are common. They're common with other disorders too, and not necessarily specific. Abdominal discomfort, weight loss are often late signs. The sad part is that usually colon cancer and polyps are not there announcing, saying, hey, I'm here, look at me, pay attention. And most often, people don't have any symptoms at all. So it's important that when you see your regular physician, that your physical includes some kind of colorectal cancer detection procedures once you reach the age above 45 or 50. How do we lower our risk? Increase your physical activity. Exercising for 30 minutes at least 3 times a week has shown to help. Not smoking, improving your diet, limiting your alcohol use, eating a high fiber diet, which is low in fat, limiting red or processed meats. Now this is all good, right? So we're doing all this, but what else? What else do we do? Get screened. And what is screening? Screening is essentially the most effective way to reduce your risk of colorectal cancer. If you have polyps, they can be removed before they turn into a cancer. And finding and removing these so-called adenomatous polyps have decreased the rate of colorectal cancer by 60 to 90%. If a polyp is removed, it doesn't have a chance to become a cancer. So regular screenings for colorectal cancer can reduce a patient's lifetime risk of dying by 80%. So bottom line, when colorectal cancer is detected early, it's highly curable. Now, there are a number of ways to get screened. There's several methods. Oftentimes, these are used in conjunction with each other, and one has to talk to their physician about which test is right for you. Colorectal cancer is preventable. The most important step is getting a screening test. There's a digital rectal exam, often done in conjunction with a flexible sigmoidoscopy. There are stool tests, which look for blood. There's also a barium enema, and most recently, the Cologuard test has become quite popular. If any of these screening tests are abnormal or positive, the next step is to do a colonoscopy. Although a lot of doctors will go ahead with a colonoscopy as the standard screening test. So what is a colonoscopy? A colonoscopy is a safe, effective means of visualizing the entire colon. It looks at the full lining of the colon and rectum using a long, flexible, sterilized tube. With this scope, we can biopsy and remove polyps. The procedure is done as an outpatient with sedation, so it's minimal discomfort and inconvenience. You require complete bowel prep to clean out, and there are various preps. The preps have changed over the years. As we were discussing, there was something called Go Lightly, which was a gallon of stuff, and one was hardly going lightly. But now you have a couple of little bottles. Again, not the best tasting stuff, I'll admit, but still much easier to palate. And when you think about the risks compared to the benefits completely outweigh the risks. The risks are pretty minimal. The worst part really is the day before, which is the clean out. But we're all adults. We've done way worse things in life, so it's a means to an end. So once this is done, you get to your procedure. It usually takes about 15 to 30 minutes. If there are polyps, it may take a little longer. You have a really good snooze, and then you're off and ready to eat whatever you want. That being said, we all know we should get them, but greater than 40% of people over the age of 50 are not screened appropriately. And when you hear all these numbers, you wonder why. Oftentimes, people are embarrassed. They want to put their head in the sand, don't want to deal with stuff like this. If you have bowel habit changes or rectal bleeding, you don't want to talk to people about it. Everyone wants to keep their private parts private, but it's important to keep them healthy. Also, people are scared of getting bad news. They worry about their families. But it's important to think about the future, and your family needs you, so staying healthy is important. And lastly, I often hear, oh, nobody mentioned my doctor. I saw my doctor. They didn't mention that I should get screened, but now you know. So if your doctor doesn't mention it, you ask them. But that being said, it's not all just about cancer, what we do. And sometimes a pain in the butt or rectal bleeding is just that. How many of you guys have had some kind of butt pain? Not everyone's telling it. Bleeding from your bottom. And when you've gone and seen someone, what have they said it usually is? It's not colon cancer usually. Hemorrhoids. So what are hemorrhoids? Hemorrhoids are part of the normal anatomy of our bottom. They're vascular cushions, which are completely normal. They are not a problem. They help keep the anus shut so that we're not constantly letting it rip as we walk around. And we have internal hemorrhoids as well as external hemorrhoids. The external hemorrhoids are the things that people feel on the outside. They're usually tissue that you cannot necessarily get rid of or push inside and ignore. And sometimes they often present as a hard, painful lump. The internal ones you don't usually feel, but those are the ones that cause bleeding or can occasionally prolapse. Sometimes you have a real pain in the behind. There's something called an anal fissure, where patients often come in and say they feel like they're passing shards of glass or someone's rammed a hot poker up their bottom. You feel the sharp tearing pain, and there's often bleeding. And what causes this? Everyone's like, I don't know why this happened, but you know what? Constipation, you have a hard bowel movement. You rip the lining, and it starts this vicious cycle. Again, there's treatment for these. Other causes of pains, you have an anal abscess, which can develop a fistula. An anal gland gets plugged up, it backs up, and causes this painful, pus-filled lump in your bottom. Drainage often helps. And sometimes you just have a good old itchy bottom. Why? No one knows. Coffee, major culprit. Nobody knows why. Other things, constipation, which is very common in our society. And then there's also something called fecal incontinence, which causes a lot of embarrassment and people don't want to talk about it. But I see a lot of this because it's very common. It can be evaluated, and there are plenty of treatments available. So anyone who's been to my office will know that I always harp on one thing whenever you have a problem with your colon or your rectum. And it's fiber. Something called Benefiber, which I truly should have invested in stocks with. You know, I've been recommending it for years, and I think it works, does miracles. So what exactly is fiber? It's a type of carbohydrate. We don't digest it. It's soluble and insoluble, but it's absolutely crucial to our diet. Women require anywhere between 35 and 45 grams of fiber, and men anywhere from 40 to 50. And most of us, as many vegetables and fruits as we eat, do not get enough fiber. Water is, again, essential, especially when you're taking the fiber. We're essentially half made of water. And typically, women require anywhere from 8 to 9 glasses a day, and men 10 to 12. 8-ounce glasses. However, the intake or the requirement varies on one's activity level, where one is living and the climate, what the metabolic rate is, and what you do. And these are the fiber supplements, so there are no excuses. So what do? We know that these are common. Avoid processed foods, eat fermented foods and probiotics, be mindful of nutrition and stress, eat smaller portions, enjoy meals together and relax, and eat healthy. If there's anything you've learned from this little spiel, colorectal disorders are common. Nothing to be embarrassed about. Recognize the signs and the symptoms. Talk to your doctor. And fiber. Eat fiber. It's going to work miracles. Who has any questions for me now? Sure.
Is it true that after you are 80, that you don't need to have your colonoscopy done as frequently as you did before you were 80?
So it takes about, they say, at least 10 years for a colon cancer to grow from nothing. So if you've had a colonoscopy and your prep was good, your cleanup was good, you have no risk factors by way of family history or polyps in the past, you don't have to go every 3 to 5 years. The recommendation would be 10 years. When you're 80, the thinking is often that if you do develop something, chances are that something will outlive you. So you're not going to die from that. In addition, you have often people have other comorbidities, meaning, you know, diabetes, heart trouble, high blood pressure, things that make undergoing a colonoscopy more tedious and difficult. So that's the basis for recommending that you don't need a colonoscopy as frequently after 80. In my opinion, if you're healthy, if you're active, and you have a history of polyps, why not?
So would you say every 5 years is good enough?
Only if we found polyps or if you have risk factors. If you don't have risk factors, if you've had a good clean out, then 10 years is good.
So the list there included fermented foods. What do you mean by that?
So things like kimchi. And that thinking comes from the fact that there's a whole new thing about the microbiome of the gut. And what they're thinking about is different pathogens, different bacteria. The colon has about 100 million bacteria in it. And they think there's certain bacteria which could contribute to the development of colon cancer. It's something that's being studied. There are different bacteria, you know, which cause, like Clostridium difficile, Bacteroides, different, and they're working to see whether those cause it. So the things like probiotics, fermented foods. If you've taken antibiotics, they've affected your gut, changed the flora or the bacterial concentration, so to speak. You want to kind of restore what you have. And the microbiome, meaning these bacteria things, basically they're shown to be, you know, of structural significance, of metabolic activity, decreasing inflammation, helping the immunologic function or the immune system of the colon.
Do you suggest a probiotic
Not routinely. There are a few probiotics on the market. What the probiotic that works for you won't necessarily work for me. And again, I think if you've had some kind of viral infection or you've taken antibiotics, if you've had something that's going to alter the flora of your gut or the bacterial concentration of your gut and disturb it from what its norm is, then yes, you should take it. Do I think one should just necessarily do it like a vitamin? No. Fiber, on the other hand, will help. Yes?
What about the fat or cleanses?
I'm not a fan of the cleanses. I'm not. I mean, I don't think they're necessarily safe. I don't think they're healthy. You will lose some weight, and that's fantastic for those few days soon after. A normal functioning colon, in my opinion, like the kidneys and stuff, if it's working well and it's healthy, will get rid of the stool and the so-called toxic stuff that it needs to get rid of. But if you're constipated, then we need to figure out why. And the cleanses, I don't understand what people try to achieve with them, quite honestly. Yes?
If you've been on antibiotics, how long does it take to recolonize the?
They want you staying on probiotics anywhere from 2 to 4 weeks.
Part of the cleanse, some people talk about doing enemas like coffee enema or other.
It's the same. It's like, I think if you're going to do a cleanse, it should have some benefit. And at this point, it's just getting rid of what people think is the toxic stool that's in the colon.
I was surprised with the list of fibers. I think avocado was on the top. I was surprised not to see grains like rice and other things on the list. As well as I was surprised to hear that you said with vegetables that's not enough fiber.
We need to get about 30 to 40, as women, 35 to 45 grams of fiber a day. When you actually, a lot of us eat vegetables, a lot of us will eat grains. Grains have a lot of carbohydrates in them too, but when you eat that stuff, we often think it's a lot of fiber, but if you actually were to break it down, oftentimes it doesn't hit that 35 grams. Or it takes a lot of effort to actually get that amount in.
Because I'm thinking of Japan or China where rice is a mainstay of the diet, and I think colorectal cancer is very low there.
It is on the lower side, but I think rice is not a primary source of fiber there. I mean, they're eating just a lot of less, their foods are not as processed as we have it over here.
Went very quickly with a picture of what's a natural source of fiber. Avocados, I got about 2. But is it possible to put that back on?
Yes.
Kiwi, I got as far as kiwi. So now, I thought that bananas were the opposite. Is that true?
They have some fiber.
Yeah, they have fiber, but do they tend to constipate?
They bulk you up. Fiber basically is a bulking agent. The colon responds to stretch. When the colon is moving, it propels the stool down. The fiber bulks up the stool, and it allows the colon to propel the bulked up stool down. It also attracts water, which softens the stool. So it helps you have a nice, easy bowel movement.
So if it's hard to do naturally, what do you recommend?
Benefiber. Benefiber. I'm sorry?
For a while, that was not available in this area.
It wasn't. The reason I like Benefiber is because unlike Metamucil or some of the other fiber supplements out there, it's very easy to palate. You mix it with a glass of water, it doesn't really taste like anything, it doesn't congeal, you drink it. And it works.
How effective is the Cologuard screening test?
I think the Cologuard is a good test. I mean, it's not invasive. It's got about a 92% sensitivity. It's not as specific. And it's a good screening tool for someone who is not at high risk, meaning you don't have a family history, you don't have any symptoms, you don't have any polyps or anything in the past, and undergoing a colonoscopy either because of the anesthesia or we're doing the prep is going to be very tedious for whatever reason.
So
It's
I just had one and I chose to not do a colonoscopy.
That's fine, but you still need to follow. I mean, just because you've had one negative Cologuard doesn't mean you don't necessarily need a colonoscopy, but you should have a follow-up Cologuard, for example. Or if you have any symptoms, then yeah.
If you've never had a colonoscopy,
The gold standard remains the colonoscopy. So nowadays, when you're not seeing colon cancers in the older age group, you're not seeing them as common in the 70, 80-year-olds. The ones I see in the office have usually been above 85, anywhere from 85 to 97, and those are all people who've never had colonoscopies ever, and they show up with a pretty advanced cancer. What we are finding now is the younger age group, so anywhere between 40 and 50, 35 and 50, there's an increase in cancer, more so rectal cancer, that's been noticed. And that's why the recommendation now is instead of 50, start at 45. And if you have a family history, you go even sooner. Like an immediate family history, like a mom, a dad, a sibling. Go ahead.
The green grapes are not as good as the red grapes as far as fiber content concerned.
I honestly don't know.
It just says red.
Yeah, it said red. I don't know. They say even with wine, red is better, right? I don't know, honestly.
Okay.
With the 80, if you've reached 80 and then you have never had a problem, they tell you 10 years, wouldn't it be smart to use at least the Cologuard after about 5?
It would be,
Yeah.
but insurances don't let us necessarily be smart. If you're 80 and you've had a normal colonoscopy, then they say you don't need another colonoscopy for 10 years. So would it be smart to use the Cologuard at about the 5-year mark? I think when you're doing a test, like with anything else, we got to figure out if we do it, what are we going to do with that result, with the result of that test? If we do a Cologuard and it's positive at 85, are we going to do a colonoscopy then? And if you're healthy and active and independent, then sure. And you can do a colonoscopy, absolutely, it makes sense. If you're not a healthy 80 or 85-year-old, then the question becomes, if you do find a colon cancer, are you going to be able to operate on it and treat it and take the increased risks of not being a completely healthy person and undergoing a major operation?
If you know that genetically you're going to live to be about 105.
Then I would do the colonoscopy. I would get a, yeah.
At 90?
I mean, I've operated on people at 90, right? So the thing with doing colonoscopies and screening is you want to prevent that bad colon cancer, because that just, at multiple levels, it affects the individual, it affects the society. So the idea of doing a colonoscopy is to prevent the cancer, or if a cancer is present, you treat it at an early stage where it hasn't spread. So if you're genetically inclined to live until 105 and you're 85, absolutely do that colonoscopy.
Do the colonoscopy. Okay, thank you.
The colonoscopy remains the gold standard.
I've read about these fecal transplants. Is that a new thing, or would you recommend that?
The fecal transplant is used most specifically for what they call a C. diff or Clostridium difficile infection. And they use it when you haven't responded to the other medical management that there is out there. It's not done, as far as I know, not done just for anything else. It's usually done to basically get rid of all that bacteria and replace it with normal bacteria. colonoscopy looks at the colon.
Right.
You can go into the very lower part of the small intestine, but essentially it looks at the colon. So when you say other intestinal,
Just bizarre patterns of transport.
well, there's something called irritable bowel.
Uh-huh.
So the question is what, what the family is experiencing, is it irritable bowel? And that is essentially a diagnosis of exclusion. So once you've ruled out with a colonoscopy, with an endoscopy, that there's no other cause for either the constipation or the diarrhea, then you can just say, okay, it's irritable bowel. But the colonoscopy, essentially, when you do it for a symptom, you're looking to see if there's a blockage, you're looking to see if there's any inflammation, you're looking to see if the lining looks normal, if there are any polyps, if there are any masses, and then you biopsy it, like for certain things like there's some people have profuse diarrhea, and it's really like watery, it's incapacitating. You get the colonoscopy, you do biopsies, even though the entire colon looks normal when you look at it, but the biopsies of the tissue show that there's a problem, and then you can treat it. But essentially, when you're doing a colonoscopy, for screening, it's basically to avoid a problem. And when you do a diagnostic colonoscopy, it's because you have a symptom, and then you're looking to see what the cause of that symptom is.
So what's the difference between diagnostic colonoscopy and the regular one?
Insurance-wise?
No.
Nothing. A colonoscopy is a colonoscopy is a colonoscopy.
No, because the way you described it, it appeared to me that there is a difference between diagnostically.
No. I mean, no.
Okay, for various things that you would examine when you go through the colonoscopy, would you say polyps are the worst, or that there could be other symptoms as well that might need some worries?
So one of the most common symptoms I see in the office is bleeding, rectal bleeding. And rectal bleeding could be from hemorrhoids or a fissure. So completely benign, which easily treatable, not worrisome. But rectal bleeding could also come from a mass, which you worry about a cancer or a large polyp anywhere in the rectum or the colon. It could also come from significant inflammation of the colon, where you have mucus, like inflammatory bowel disease, ulcerative colitis, Crohn's disease. So when you're doing a colonoscopy, it depends, right? I mean, if you have a cancer, would I say that's one of the worst things you can have? Sure. But then there's stuff like ulcerative colitis or Crohn's, which if you can't get control over that, can be very incapacitating for the individual who has it and has to deal with it, because it becomes like a chronic disease.
Could you talk about diverticulitis and diverticulosis?
So diverticulosis is super common, as is diverticulitis. Diverticulosis, basically, as we age, related to diet, related to constipation, these little outpouchings form in the colon, and they're little weak spots. And sometimes they get plugged up, or that area of the colon gets inflamed, and then you develop what is called diverticulitis. You have an intense pain, usually, in your left lower abdomen or the lower abdomen, and it can be associated with a fever, diarrhea. Now, diverticulosis is very common, diverticulitis is common, and there are different types of diverticulitis, so it can manifest differently. You can have just the regular inflammation of the colon, which oftentimes does not even require a hospital admission. You can have bleeding from diverticulosis, which usually happens without any inflammation or pain, but you have massive bleeding. You can have narrowing of the colon, or where it just becomes more scarred and forms a blockage or an obstruction. You can have a perforation, when one of those little outpouchings just pops, so to speak, and you can have a little air outside the colon, which is not normal, and then it forms like an abscess infected cavity. Or you can have a frank perforation, where we're needing to rush you emergently to the operating room because you just can't move and you're in so much pain and the infection is bad. Again, if you have the pain, get medical attention, and then one way to prevent it, fiber, because you don't want to be constipated.
If
About a month,
About a month and that's it? After that, we don't need to continue it?
correct.
Do you like a line or what's your opinion?
I think a line is fine. I think it works. I don't necessarily recommend taking a probiotic unless you've had an antibiotic that you've used and you're worried about some change in the normal milieu of the colon. So I wouldn't take it just as a random supplement. Yes.
What about preventive stuff? Like I come from Europe, and so we have some preventive stuff first thing in the morning. Apple cider vinegar with hot water. It works. It cleans you out.
If you're not constipated,
But I mean, doesn't nothing that they recommend here that you start with some natural stuff first?
the fiber is the big thing that has been shown to be of help. The rest of the stuff, like we talked about, the microbiome or the micronutrients to the colon, it's all being studied right now. There's no definitive data in humans whether it definitively helps or doesn't help.
So, do only fruits have high fiber? What about the other food?
No, vegetables, fruits, legumes.
Okay, so not just fruits,
No.
right?
I have two questions.
Yeah.
One is, I'm assuming you don't want me to go home and eat 4 avocados a day only.
No,
And
no.
bulk up. So, is a balanced diet really important? I assume that's what we're taught, right?
The Mediterranean diet, they say, is like the perfect diet almost, right? Yes. A balanced diet is always good.
Yeah, okay, so you definitely promote that, but at least trying to fit in, I guess, 4 avocados and stuff.
Well, I don't know if, 4 avocados is a lot. I like avocado
Man,
toast and
I gotta
stuff.
get up to 40 though, right?
You do, but not with just avocados, unless you
Yeah.
really like that. But
Okay. My other question is that, and this is just a general question, I don't know about your specialty. Why do you stop at the large intestine? Why do you not go up into the small intestine?
with a colonoscopy,
No, just studying and analysis. So it sounds like your work stops at the top of the large.
yeah, my dad asked me why I chose the profession too, but it's just,
Well, not the
no-
profession, I'm just saying, it seems to me that maybe, I would be asking about my small intestine, my stomach, my esophagus.
so the small intestine is probably the weakest studied, the least studied of. It's easy to access the stomach. You go through the mouth, you get into the stomach, and you see the first part of the small intestine. And it's easy to go up the behind and get a good look at, The small intestine is not that easy to maneuver. So you have things like capsule endoscopy or barium swallows, and they take x-rays. But it's this long, floppy, coiled tube, which never sits still. So it's just loosely attached, and it's very nebulous, and it's going. So I think that makes it difficult to study. Are there small bowel tests? Yes. Are they as specific as these ones that we do for the stomach or the colon? No. It's a good question, but the best thing they've come up with is basically like an MR, what they call MR enterography or CT enterography. Or you're swallowing a capsule, and it kind of takes this little video or pictures of the small bowel. But it's difficult to get like a tube, a rigid tube or a semi-rigid tube up there and examine the whole thing. Has it been done? Yeah, when you're in the operating room, and you can intubate quite a bit of it under, with some assistance, but it's not easy physically to do like one would do a colonoscopy or an upper endoscopy.
Would you say there's a bit we don't know about the small intestine?
There probably is.
But we know a lot about the large intestine.
Yeah.
But is that a problematic area, small intestine?
Small intestine disease is rare, or relatively rare compared to what we see. Is it because we just don't know, and we've studied the other stuff more? I don't know. But you don't see small intestinal cancers or small intestinal inflammation as commonly as you see stomach and colon.
What are the symptoms of irritable bowel syndrome?
Classic bloating, just bloating, and then what they call alternating constipation and diarrhea. And then it can be either, more constipation or leaning more towards diarrhea. And usually the bloating goes away after you've had your bowel movement. But that being said, if you're experiencing symptoms, don't just assume it's irritable bowel, because irritable bowel is what we call a diagnosis of exclusion, meaning when you've said it's not this, and this, then it can be irritable bowel. Or then it's probably irritable bowel. There's also a strong association with stress as far as irritable bowel is concerned, but then there's a lot of GI stuff that's associated with stress.
So are both forms of fiber good, soluble, insoluble?
Yes,
Okay.
yes.
Do you think the age for colon cancer is now much younger?
I think we don't diagnose it. We haven't been diagnosing it. So the focus was always at 50, you start your colonoscopies. And so everyone was going at 50 and finding stuff, and then it wasn't developing into anything. So you don't see that, 50 to 70 age group, or the colon cancer incidence has dropped in that age group. But I think they're younger patients. And again, it's probably diet related, it's probably familial, although familial is only about 10 to 20% of colon cancers. Most of them are still sporadic, which means just occurs in the community.
So I'll ask the same question that your dad asked you.
Why did I do it? He thought I should do plastics. I don't know whether he was embarrassed or... I think it's fun. I think, I did general surgery. I liked operating on the belly, and then I had to decide if I wanted to do a specialty, and I decided I wanted to do a specialty and get a second board certification in it, because a little ego came into play probably. But it's a good variety of cases. So we're in the office. In the office we can do, like minor procedures for hemorrhoids and things like that. We do the colonoscopy, so again, it's like a different thing, different day. And then we do the big operation, so there's a nice variety. And you can see the results. So even when someone has what they call a thrombosed hemorrhoid, for example, a lot of us just minimize it and be like, oh, it's just a hemorrhoid. But when a patient walks in and can barely walk because the pain is just so damn bad, and then you remove that hemorrhoid, and then they're like suddenly much better, it's quite gratifying. So you see the results, and the variety is always nice too, and it's clearly something that affects our society, and knowing that you can somehow make some kind of change is always nice. Maybe I should have done plastics, I don't know.
They still do sigmoid, I can't pronounce it.
Sigmoidoscopies,
Yeah.
they do, not as commonly anymore, and usually you want to do it because now, initially when colon cancer was diagnosed, most of the colon cancers were on the left side of the colon, so kind of towards the end. So this sigmoidoscopy looks at that portion. Now you're seeing about half of them even on the right side. So when you're doing a sigmoidoscopy, you usually do it in conjunction with like a fecal occult test or some other test to make sure.
I had an internist that did that generally from about the age of 30 on. Probably effective.
Yeah.
Why the change?
Well,
That now we're getting
They
more
don't know.
right-sided colon.
I
Very
know.
strange.
Mhm.
Maybe we just weren't.
We weren't looking, exactly.
So you said that diet can have a tremendous impact on prevention of colon cancer. I'm curious, does it have an impact if you already have cancer?
I think
Fiber,
once,
you're talking about.
well, no, once you have the cancer, it's there. Once you have the cancer, a change in diet is not going to make the cancer go away. That cancer needs to come out. So you're operating and you're getting out. Altering your diet will likely help down the road, not necessarily, I mean, once you have the cancer, you have it. So will it help not predispose to another cancer developing or polyps forming? Potentially. But it won't, altering your diet is not going to get, it's not going to get rid of the cancer. So once you have the cancer, you got to get it out.
Diverticulitis, a long time ago, they used to say no seeds, no nuts.
There is no data to document that you shouldn't have them. That being said, most people will come and say, I had popcorn, I had a bunch of peanuts. There is no data to say that that causes the diverticulitis. So just chew, whenever you're eating them, chew it well. Good.
Any data on bowel rest after you have an acute diverticulitis attack?
Bowel rest helps with decreasing the inflammation. So initially, whenever anyone comes in, you will keep them on bowel rest and then start off with clears. And then what we want ideally is a low fiber diet, which is easy to digest and not causing any roughage, so to speak, on the inflamed tissue. And once all the inflammation is healed, which is usually about 2 weeks, at the 2-week mark, or you assume it's gotten significantly better, go back to the high fiber.
Because I get these questions all the time because I treat this. My friends always ask me, like, so, I'm like,
You're a doctor.
I had to go, not today, so look.
What's the probability of polyps occurring again in the next 5 or 10 years?
They say as high as a 25% chance.
25% chance. And let's say that you do have a polyp since your last
Yeah.
colonoscopy. What's the probability that it will be cancerous?
If you've left it in place,
No. You had the polypectomy done.
yes.
And now there are twofold questions. Number one is that what's the probability of its reoccurrence?
It could recur depending on the type of polyp it was
I see.
and how completely you removed it. So if you have polyps found, depending on what type of polyp they are and how many or the size of them, you would recommend a colonoscopy anywhere from 1 to 3 to 5 years. So if it's a tiny, like a 2 mil, when you do a colonoscopy, things look much bigger because they're a little magnified. But if it's like a millimeter or 2 millimeter polyp and you just find one, then you could even argue that you wait 5 years, assuming that your clean out was good and the person doing your procedure got a good look. If you find a cancer 5 years out, or it's could be either that the prep wasn't that good, that someone missed something, or you have a more aggressive polyp that kind of developed. And there is a miss rate, no matter how good you are, there is a miss rate. It's not a perfect science, so there is a miss rate. Ideally, you choose not to do that, and that's why I think a lot of us will call you back in 3 to 5 years, just if you have a history of polyps. But if you've gotten a good clean out and you've gotten a good look, then you're good for 10.
My father had colon cancer, and my siblings and I confessed it, and we all have polyps. They constantly remove them, but I had one removed that was 3 centimeters, 3 millimeters, after 5 years. So then the doctor said, well, I did a year following, and it was fine. And then now they're saying every 5 years, but considering the 3 centimeters in 5 years, I keep insisting 3 years.
3 years.
They're telling me 5, and I keep saying, no, I want to do 3.
So we recommend that if you have a family history, even if we find nothing, we do the 5 years. If you had a polyp, one could argue to do it in 3. That being said, it was a tiny polyp and it was 1. So the chances of it really becoming anything of significance is pretty low.
What would be considered a big polyp?
Anything greater than a centimeter is it's considered an advanced polyp. And then depending, when you send it to pathology, the type it comes back as. High fiber, relatively low fat, low processed foods, low alcohol. Everyone's going out for everyone. Yeah.
Does that include red wine?
Huh?
Does that include red wine?
I
keep hearing
strongly
red wine
advocate
is
a
good
glass
for
of red wine every so often, but that's.
So do I.
I think everything in moderation is good, right? I mean, one has to live a little bit.
Any other questions?
Not no alcohol.
You also mentioned fermented foods. What are some examples of that?
Kimchi.
Isn't that something you buy and you drink?
No. No, you can get like, like shakes and stuff which are fermented, but kimchi is, it's like a Korean pickled cabbage and radishes and things like that. Sauerkraut.
What's the cause of polyps anyway?
When you figure that out, please include me. We'll make a lot of money together. Yeah, that's the $1 million question. Nobody knows. What happens is you have like some change at the genetic level, at the DNA level that causes it to happen. But why exactly, or why definitively, no one knows.
What was the question?
Why do polyps happen? I mean, there's some genetic conditions which predisposes people, and in certain cases, in certain diseases, there have been documented gene defects. But for the regular polyps in the regular society, no one really knows why.
Well, if there are no more questions, you want to join me in thanking the doctor for her time?
Thank you.